Welcome back to the lecture series on periodontics. In today's video, we will be discussing an important acute gingival condition, which is necrotizing ulcerative gingivitis, which is also known as acute necrotizing ulcerative gingivitis or simply necrotizing gingivitis. Let's dive into it. Necrotizing ulcerative gingivitis is one of the acute gingival infections which is characterized by the rapid onset and pain and ulceration of the gingival tissues. If it is left untreated, it can progress to more severe forms of periodontal disease known as necrotizing ulcerative periodontitis, or it can even progress into necrotizing stomatitis. Next is etiology. The primary cause of necrotizing ulcerative gingivitis is fusospirochetal complex, which is including the fusobacterium and spirochetes. So these bacteria are interacting with the host tissues and immune cells, leading to the tissue destruction and necrosis. Predisposing factors of ANUG include stress, smoking, malnutrition, lack of sleep, poor oral hygiene, and immunosuppression. Next, let us discuss about the clinical features of acute necrotizing ulcerative gingivitis. This is the image of the acute necrotizing ulcerative gingivitis. So if you look at the gingiva here, at the interdental gingiva, this is the tip of the interdental gingiva. So you can see the punched out or crater-like depression at the tip of this interdental papilla, and you can see a whitish membrane over here. This whitish membrane is known as pseudomembranous slough. So this grayish and whitish membrane is covering the underlying ulcerated areas. So this whitish membrane or pseudomembranous slough is not a true tissue. It has dead cells and it has bacteria and it is having the inflammatory cells. And you can appreciate a red color border just beneath the pseudomembranous slough clinically. So this is known as linear erythema. So this is a bright red border which is surrounding the lesion, which is distinguishing the diseased tissue from healthy tissue. Above the linear erythema is the diseased tissue and below this is the healthy tissue. And there will be a spontaneous bleeding from this area. Even without the provocation, you can see the bleeding from this area. These are the clinical signs. Next, let us move on to the clinical symptoms. What the patient feels and what the patient reports. Patient will always complain of severe pain. So he complains of a continuous and a radiating and gnawing type of pain. And this is getting worse with the hot and the spicy foods. Patient also complains of metallic taste. And he complains of fetid odor, which is because of the bacterial infection and tissue destruction happening in the oral cavity. And patient also notices pasty saliva. So these are the clinical symptoms of acute necrotizing ulcerative gingivitis. Next, let us understand what happens at the microscopic level. In acute necrotizing ulcerative gingivitis, under a microscope, we can see complete destruction of the surface epithelium. If suppose this is the epithelium and this is the underlying connective tissue. Okay. There is a complete destruction of the surface epithelium, which is replaced by a mesh-like layer of fibrin and necrotic epithelial cells and neutrophils. So this is clinically visible as pseudomembranous slough. And connective tissue beneath the ulcer is highly inflamed. So the connective tissue is highly inflamed and it is engorged with the blood vessels and heavy neutrophil infiltration is present in the connective tissue. So this is clinically appearing as linear erythema. A transition zone between the necrotic and the healthy epithelium where the fusiform bacteria, spirochetes, leukocytes and also the fibrin are abundant. So this histological pattern explains why the lesions appear as punched out ulcers which are covered by the pseudomembrane and why the condition is painful and destructive. Next is differential diagnosis. Conditions that mimic necrotizing ulcerative gingivitis. Other conditions that may present similarly include desquamative gingivitis, diphtheria, secondary syphilis, streptococcal gingivostomatitis, and candidiasis. A proper clinical examination and medical history help in confirming the diagnosis. How do we treat necrotizing ulcerative gingivitis? During the first visit, isolate the affected area and apply the topical anesthesia for comfort, and remove the pseudomembranous slough by using a moist cotton pellet, working in small sections, and discard each pellet after the use. Rinse with the warm water after cleaning. If any caliculatus is present, perform gentle supragingival scaling with the help of an ultrasonic scaler. Avoid subgingival scaling, extractions, and periodontal surgeries during this acute stage of the disease. During the first visit, antibiotics can be given only if the systemic symptoms are present, like fever or swollen lymph nodes. What antibiotics can be prescribed? Amoxicillin can be given. If the patient is allergic to amoxicillin, then erythromycin or metronidazole can be prescribed. And what are the home care instructions for the patient after the first visit? Ask the patient to avoid the smoking and alcohol. Ask him to rinse with a 1:1 mixture of warm water and 3% hydrogen peroxide for every 2 hours. And patient is advised to use chlorhexidine 0.12% mouthwash twice daily. Ask the patient to rest, to hydrate, and avoid physical exertion. And patient is advised to use the ultra soft toothbrush with a bland toothpaste, or just he can use the plain water. So after the first visit, patient is advised to come back to the clinic after 1 to 2 days for follow-up. So during the second visit, assess for the improvement in the pain, swelling, and necrosis. And if needed, you can perform the scaling and give the oral hygiene instructions again. And recall the patient after 5 days. So during the third visit, you can plan for the long-term periodontal care and ask the patient to stop hydrogen peroxide rinses, but he can continue the chlorhexidine rinses for another 2 to 3 days. You can perform further scaling and replaning if necessary, provide nutritional counseling and also smoking cessation advice, and emphasize long-term plaque control.
If you found this video helpful, hit the bell icon below and subscribe to my channel, and stay tuned to Tooth Fairy Tales for more dental videos.